All right, welcome back, guys. Let's start with malabsorption syndromes. Malabsorption syndromes. They can cause, all of them can cause diarrhea, steatorrhea, weight loss, weakness, and vitamin mineral deficiencies. Screen for fetal fat, which is a Sudan stain. Okay. Steatorrhea is going to give you fat in stools, right? Fat in stools. How do we know it's a fat in stool clinically? Well, it's a bulky, foul-smelling, hard to flush. Bulky but hard to flush. Stools don't even flush. You're like, hey, something wrong with the water? No, man. You just got a lot of fat in there. Okay. So, and also vitamin deficiencies. Which vitamins? All the fat soluble vitamins. A, D, E, K. Right? But A, we have a lot of stores. So D, K. Okay. And what else? You have, that's pretty much all you have for all of them. And how do you check this out? All of that fecal fat, Sudan stain. Okay. Now let's talk about celiac disease. Celiac disease, it's also called gluten sensitive enteropathy, celiac sprue, autoimmune mediated intolerance of the gliadin, which is a gluten protein found in the wheat. Gliadin is what? Very important. It's a gluten protein. It is found in wheat, barley, rye. It is associated with HLA DQ2, HLA DQ8. What is an autoimmune disease? So just HLA. 3 wording HLAs, okay? But okay, if you want to remember it, great. Northern European descent. Primarily affects the distal duodenum and or the proximal jejunum, leads to malabsorption and steatorrhea. Treatment is gluten-free diet. Now the important thing is, you are taking gluten-free diet. What can you take? So of course you're not eating any wheat, barley, rye, and also you're on the gluten-free diet. But you can eat rice. Okay. It is associated with dermatitis herpetiformis. Very important. Decrease in bone density because of that vitamin D deficiency, leading to decrease in bone density. Moderately increased risk of malignancy, example T-cell lymphoma. Okay. A D-exilose test, we talked about that. This is abnormal. Why? Because you have a mucosal damage. When you have a mucosal damage, that D-exilose is not going to go in. When it's not going to go in, it's going to go straight out. So you will not, when you do the blood testing, you will not see any, or urine testing, you will not see any D-exilose, and you'll be like, okay, that's something is got to be wrong with the mucosal damage. Something is wrong with the mucosa. And then with the other testing, you can figure out, okay, yeah, it's celiac disease. With serology, you have a serology going to be positive for IgA anti-tissue transglutaminase, IgA TTG, anti-endomysial, and anti-deaminated gliadin peptide antibodies. Okay. On histology, very important, you will have villus atrophy. Look at this picture, villus atrophy. How do we, okay, let me just draw here. So you have, normally you have this, you have the villi. This guy is the villi. And you have the creps. Villi, creps. Forget this thing. Okay. So here normal is always this. Okay, normal is always here. Like you have the villi and the caps. That's normal. But here, what's going to happen? Well, here you are going to have villus atrophy. Let me change color so you can see. Villus atrophy. So these villi, they are atrophied. So instead of all of that big, nice villi, you have very small villi, atrophied. Okay, and you have the crypt hyperplasia. So instead of these, I mean, I drew them a little bigger, but they undergo hyperplasia. Okay, and the third thing here on histology, you have intraepithelial lymphocytosis. So you have the lymphocytes in these cells, intraepithelium, in the epithelium of these cells. You have that. Okay. Let's look at this picture, which is the pathophysiology here. Gluten, you eat wheat, the gluten gets into your converted into the gliadin. Gliadin gets absorbed, and tissue TTG, tissue transglutaminase, acts on that gliadin and forms a deaminated gliadin. That deaminated gliadin now gets and the APCs, they catch it and they bring it to the T cells. Okay, when they bring it to the T cells secrete the B cells to make antibodies against this. B cells secrete those antibodies having anti-TTG, which is right here towards this thing, anti-deaminated gliadin, which is right there, and anti-endomysial antibodies. Well, endomysial antibodies are maybe probably mucosal damage. Okay, so that's how things are really working out there as a pathogenesis. Now let's talk about dermatitis herpetiformis. Dermatitis herpetiformis is basically what you have. You have the epidermis, normal skin, right? So you have the epidermis, and below that you have the dermis, right? That epidermis does not have any blood flow, but the dermis has the blood flow. So no blood flow, yes blood flow, right? So you have these blood vessels in the dermis. This is epidermis. So now what's going to happen is, you have this what is it? So you in the blood, those IgAs, they're going to come here and they're going to get deposited in these blood vessels. So when they deposit in these blood vessels at the tip of these dermal papillae, this disrupts the epidermis to dermis at this point. So because they have deposited here now, so you lost that connection between epidermis and dermis. Okay, that leads to formation of, because you have now here, there is a proper small herpes-like lesions because you have deposition of those IgAs. So you will have herpes-like lesions that you can see on the epidermis. That is called dermatitis. It's herpes-like, so that's why it's called herpetiformis, herpes-like lesions. Okay. What else? You might have, what else? Let me just figure out. Yeah, one more important thing is about this T-cell lymphoma here. T-cell lymphoma. In this T-cell lymphoma, so even if you give, now the thing is, despite the question is, you say, hey, we are treating this patient right. He's not taking any gluten, but still, you have these celiac disease sign symptoms or celiac disease induced or pathology, but you are on a strict gluten-free diet, not eating anything. So that is due to your T-cell lymphoma. So the way it goes is, despite good dietary control, there is a moderately increased risk of malignancy of T-cell lymphoma, which is called EATL. EATL. EATL means enteropathy-associated T-cell lymphoma. This leads to formation of the celiac disease. Celiac disease, even though the patient is already on a strict diet. But this, you can decrease the chance of T-cell lymphoma messing up things. Okay. All right. So one more thing is differentials to this thing. Differential to celiac disease is, all of them that details that I'm talking about, it might sound like, hey, it's too much, but this disease is very important, very important. Okay. So they're going to confuse you with the differential diagnosis, giving you some same thing, but it's not celiac disease. What are that thing? So you have this, you have to differentiate this with the chronic pancreatitis, which is going to come later at the bottom now, right here, pancreatic insufficiency. Chronic pancreatitis / insufficiency. Okay, so let's just move on with the lactose now. Lactose intolerance. Well, this is pretty simple. Lactose normally forms into your glucose and galactose by the help of enzyme called lactase, right? So if you have this lactase deficiency, you cannot form glucose and galactose, and that lactose remains in your lumen. You will have a normal appearing villi because there was no inflammation, and except when secondary to injury at tips of villi. Okay. Again, same thing. Let me tell back again. Normal appearing villi, except when there is a secondary injury to the tips of villi, viral enteritis. Because of that lactose, right? That lactose is going to give you an osmotic diarrhea with a decrease in stool pH. Colonic bacteria ferments the lactose. Chronic bacteria ferments the lactose. This leads to decreases in the stool pH and also causes gas production. Okay. So now in lactose, just remember lactase deficiency, but the villi are normal. Okay. And you have an osmotic diarrhea. Why? Because of that lactose in the lumen that leads to osmotic diarrhea. Everything else is normal. You will have a normal iron levels, vitamin D levels. Biopsy will show you normal villi, but you have diarrhea. As soon as you take some milk products, very important. Where do we get the lactose from? Milk products. So the case is when we gave milk to a child, it presented with the osmotic diarrhea. Okay, that's the watery diarrhea with not just osmotic diarrhea, but you will have abdominal pain and abdominal distension. There is no weight loss here because there is no deficiency in calories. So they will say, do you have lactose intolerance? Do you have weight loss? No, there is no weight loss. Why? Because you're not deficient in calories, man. I mean, it's just that you take milk, you have that. I mean, milk, you don't even take milk, you're fine. You can live without milk. Okay, lactose-free milk, actually. Okay, what else? So what you can do is you can do lactose hydrogen breath testing. It's positive for lactose malabsorption if post lactose breath hydrogen values increases greater than 20 compared with the baseline. Okay, this is the testing that you can go for. But also you can also have you will have decrease in stool pH. That's another indicator. You will have increase in stool osmolarity due to lactose being there, right? So what is the treatment of all of this? Treatment is avoid milk products. Exception is yogurt. You can have yogurt. Okay, you can have yogurt. It's just milk that you don't want. Okay. That's all we have for the lactose. Now let's talk about pancreatic insufficiency. In pancreatic insufficiency, it is due to chronic pancreatitis, cystic fibrosis. So they're saying, why would you have pancreatic insufficiency when when you have the chronic pancreatitis? It leads to insufficiency. Cystic fibrosis causes chronic pancreatitis, that leads to pancreatic insufficiency. Obstructing cancer again causes chronic pancreatitis, which causes insufficiency later on. So when you have this pancreatic insufficiency, it leads to malabsorption of fat and fat-soluble vitamins A, D, E, K, as well as vitamin B12. Remember, the pancreatic proteases, they were the ones which were, removing that R binder from the B12 so that the intrinsic factor can bind. So when you don't have the proteases, pancreatic insufficiency, so you cannot remove that R binder. When you cannot remove that R binder, that is going to remain with the B12. So that B12, which is go to terminal ileum, you have no receptor for you already have receptor for IF. So that B12 is not connected with IF. IF is going to go back, but B12 is going to go poop, poop, bye-bye. Right? You have, what else? Let's talk about this thing. You have decrease in duodenal bicarb, for sure. Bicarb. You don't have a pancreas. How are you going to have a duodenal bicarb? Or are you going to have it decreased? You can have the bicarb, remember, from duodenal Brunner cells, right? But also, pancreas also secretes bicarb and high flow bicarb. High flow bicarb. If you know what I mean here, you can look at the other videos and it's going to tell you high flow, low flow pancreatic secretions. And also you have a fecal elastase, okay? And D-xylose test is normal. Why? Because you don't have any mucosal damage. You have a pancreatic problem, but not the mucosal problem. All right. Excuse me. Moving on with the tropical sprue. Okay, one more thing. See, I did mention that that's a differential diagnosis for celiac, right? How? Because the presentation is going to be similar to celiac disease, but with no iron deficiency. In celiac, you will have iron deficiency because you are messing on the duodenum. That's why in celiac, you have the iron deficiency. But here you have no iron deficiency and you have a normal D-xylose test. In celiac, you have iron deficiency and you have an abnormal D-xylose test. Right? Right. Great. Moving on with the tropical sprue. What do we have? Coming back, look at the treatment. How can you treat this guy? You give digestive enzyme replacements. You want to give those pancreatic enzymes back to the person, and he is all new. Okay. And one more thing here, I just thought about it. This is decreased fecal elastase. Why? do they even have to mention this? Remember, the elastase was the enzyme coming from pancreas, right? So when we don't have any pancreas, there is going to be no elastase. So all they had to mention is decrease here, but they decreased all of them. Yeah, it's just point that they mentioned. So that's all for the pancreatic insufficiency. Let's talk about two infections here now: tropical sprue and Whipple disease. Tropical sprue is similar finding as celiac sprue, affects the small bowel, but responds to antibiotics because it's an infection. Cause is unknown, but it is seen in residents of or recent visitors to tropics. Right? So, for these two things, Whipple disease and tropical sprue, bowel wall biopsy shows specific organism. So when you do the bowel wall biopsy, there is going to be specific organism causing all of this malabsorption syndrome, like malabsorption, right? Fat malabsorption. So you can just right away tell it's the either this or that, but this we already know. But tropical sprue, either the guy is a visitor, came, he visited the tropics, or it was a resident of the tropical areas. Tropical areas meaning Caribbeans. Okay, basically you have a history of travel to the Caribbeans or Caribbean islands. Treatment is, how do you treat this guy? Treat this guy by giving antibiotics, trimethoprim, sulfamethoxazole, or you can also give doxycycline. That's the treatment. Tropical sprue decrease mucosal absorption, affecting duodenum and jejunum, but can involve ileum with time, associated with megaloblastic anemia due to folate deficiency. So remember the folate: iron, fist, bro, iron being duodenal absorption, fist being all small intestine, bro means ileal, B for B12, for F for folate. So you have all of them, all three of them. So you have folate deficiency, vitamin B12 deficiency, and also you can have an iron deficiency. But megaloblastic anemia due to folate, and first the folate and later B12 for megaloblastic anemia. But that does make sense. But now the last thing here, we have the Whipple's disease. It is the infection with the Treponema Whipple. They are the intracellular gram positive, PAS positive foaming macrophages in intestinal lamina propria. B, they are filled with PAS positive. What is PAS? That's the periodic acid skiff stain. Okay, so you have all of them. You can see here. They are the PAS positive material. They're filled with the PAS positive material. All of that red thing that you can see here. Cardiac symptoms, very important. And this thing very important. So in Whipple, you just don't have diarrhea. You have some other features too. So PAS, the foamy Whipple cream in can. So you have this diarrhea. But with that, you have cardiac symptoms, you have arthralgias, you have neurological symptoms. On top of all of this, you also have diarrhea, steatorrhea, which can come later in the course. It is seen in the older males. So what sort of neurological findings you can have? You can have ocular findings, and also you can have like dementia, seizures, etc. You can also have lymphadenopathies, fever. Okay. Now this Whipple, T. Whipple, it's a chronic bacterial infection with T. Whipple, right? T. Whipple is a rod-shaped bacilli, which is a diastase-resistant granules, and are loaded with foamy macrophages. So what happens is basically T. Whipples, they get loaded in the macrophages. That forms the formation of foamy macrophages. Okay. Now one more thing, that the glycoprotein cell layer of the glycoprotein cell wall of T. Whipple colors magenta. Pink. Magenta means pink. Okay. And it is diastase resistant. Diastase resistant. So this pass, why am I saying all of that? Because this pass, periodic acid skip stain, this highlights, what does it highlight? It highlights or demonstrates the glycogen. Okay. Or it highlights the polysaccharides or monosaccharides and the glycogens. So what now the whole thing happens is T. Whipple is taken up by the macrophages, right? And it interferes with when it's taken up by the macrophages, normally macrophages destroy them by phagocytosis. Now T. Whipple is a really smart guy. So what they do is it interferes with that, with its phagosomes. So when it interferes with the phagosomes, so it doesn't get destroyed within the macrophages. So it replicates. And within the macrophages, and this, where all of this occurring, this is occurring in the lamina propria. Lamina propria. What is that lamina propria? Well, lamina propria, also think about it. Lamina propria is the place where all the fats get absorbed as chylomicrons, remember? So chylomicrons. So in the lamina propria, you have all the fat, right? So that gets absorbed from the lamina propria, from the lacteals. In the lamina propria, you have the lacteals. Lacteals are the lymphatic channels that get all the fat, and through lymphatics, the chylomicron go into the blood, right? So that lamina propria now has been bombarded with all these macrophages. So those lacteals, they are compressed because of the macrophages' presence, right? So when they are compressed, so no more fat absorption, right? When you don't have any fat absorption, that all of that fat which was normally getting absorbed through lacteals now, it cannot be absorbed, so it's gonna go out into the lumen. It remains in the lumen. When it remains in the lumen, it leads to steatorrhea. Okay, that's the mechanism. Okay, treatment for this thing again. You can give antibiotics. Which antibiotics? Ceftriaxone, followed by trimethoprim, sulfamethoxazole. Okay.